Hi, I'm Dr. Praveen. I'm a consultant physician working at Hyderabad in India. Today in this video, I'm going to talk to you about history taking skills, which is your station 2 in MRCP PACES exam. As you all know, the station is for 20 minutes. You'll get 14 minutes for your history taking. There will be a 1 minute gap after that. The examiners will give you time to collect your thoughts. After that, there will be 5 minutes for the questions and assessment by the examiners. They are mainly trying to score you in differential diagnosis and clinical judgment. Okay, that's how the time distribution happens in the station. And with, within the 14 minutes of history taking which you do, there will be a 12-minute mark where the examiners will inform you that there are 2 minutes left. Okay, so this is done for a particular reason. The main reason is that during this 2 minutes, last 2 minutes time, you're expected to get into little bit of communication. As you know, the history taking scenario is where you ask a lot of questions. The patient or the surrogate will give you the answers. But the important part is in the history taking station, it's not just about uh, questions and answers, but the patient is also there to hear from you as to what is wrong with them and what is the plan, what investigations you're planning, what treatment you're planning, or if you're going to refer to any particular specialist. So there is a little bit of communication involved in the history taking station. So for the last 2 minutes which you get, my suggestion to you is that use that time for communication. All right, wherein if you are taking history still, better to wind up quickly and then start talking to the patient, asking them concerns, what concerns they have, and how the current problem which they are facing is impacting their job, and also explain to them, more importantly, about the plan that you're going to make, what a diagnosis or differential diagnosis you had considered, and what you are going to do next. When you're doing this, it's very, very important that you avoid jargon. It's very common for doctors to talk in medical language, but it's important in the exam to speak to the patient or the surrogate in a language which they understand. So practice as much as you can and see to it that you avoid medical jargon as far as possible. And when you are communicating in those 2 minutes period, you should be as simple as possible. You need not explain everything that you're planning, okay? Because 2 minutes is a short time. But if suppose you finish early, yes, you have time to spend, you have a gap to fill, so you can talk, you can explain in detail what you're planning. But if you happen to reach a point where you have only 2 minutes left and you're into this communication mode, use that time properly. So, what I'm going to talk about in this video is about history taking skills. I'm going to discuss what you should be doing, what you should not be doing, how you should be adjusting your time, and if you happen to leave a big gap, you finish the questions early, and you don't have much to ask, don't have much to talk to the candidate or the surrogate, how to fill this gap is what I'm going to explain to you. And finally, what questions you can expect, how the examiners will ask you questions, and how you're supposed to answer. So we're going to cover all these things in our video today. And please try to watch till the end of the video, and I hope it will be useful for you. Okay, as I told earlier that we're going to discuss a little more detail about the history taking skills. So we're going to dig into the main topic now. So when you have a history taking station, you will get the scenario which is kept outside. There is a brief information which is given to you, and you'll have 5 minutes to go through that. So in that 5 minutes, you need to prepare yourself, and the way to prepare is very simple. You all know the various headings under which you take the history taking, but you can put the list of all those subtopics on a rough paper, which is also provided to you outside the station. And what you can do is, as you know, in the history taking, you have history of presenting complaint, you have the system review, which you should actually practice asking questions of system review in a very short and a quick manner. But doesn't mean that you have a rapid fire round where you ask multiple questions in one go. But you need to cut short if required based on the kind of the problem the patient comes. Let the system review not go on for minutes and minutes. Okay, so system review has to be there, but let it be as brief and precise to the particular case that you have got. And the next will be your past history, family history, medication drug history, and there is social history, there is a personal history. In the personal history, you can also ask about the obstetric and the menstrual history in case of a woman, and also any history of sexual history also comes under the personal history. Then you have the occupational history, dietary history, and a travel history. Now, when it comes to dietary history, I see that many times in the exam, the candidates do tend to miss the dietary history quite often. My suggestion to you is that if you have a case situation where it is a problem of weight gain or weight loss, a patient with anemia, a patient who has paresthesias, sensory paresthesias, and then you're taking a history in such cases, you cannot miss a dietary history. It becomes very relevant in these situations at least. So can't miss a dietary history, but it's not a big punishment if you miss it in other situations. But weight gain, weight loss, paresthesias, a case of anemia, in these kind of situations, dietary history is very important. Then comes the travel history. And you might in the end ask an open question to the patient. I've asked you so many questions till now. If I have missed something to ask, or if you have something to tell me which I haven't asked, you can tell me now. So this is a list of the headings under which you will be conducting your interview once you go inside. So make a rough list on your rough paper, a brief abbreviation like PHX, FHX, like that, so quickly for you, so that you get reminded when you are in the station and you're performing. In that case, you don't miss covering any of the history taking parts. Okay, so now when you're outside and your 5 minutes are done, you will be entering the station. But before you enter, many of you have a habit of writing down the differential diagnosis. Yes, that's not a bad idea, that's not a bad thing to do. You can write the differential diagnosis, what you think that this case most likely can be. But my suggestion again to you is that don't get fixed on that differential diagnosis only. The reason is very simple. The reason is that it's likely that when you go inside and you start taking the history, the story may be completely different. So don't be so fixed that it has to be one of these differential diagnoses which you thought was right outside the station, and when you go inside, you're already quite biased and your history is directed only in one particular direction, and you're not taking any cues from the history which the patient is giving you. So good thing, make a differential diagnosis. I'm not saying not to do it, but be open and listen to what the patient is saying so that you actually make the correct diagnosis or a correct differential diagnosis. Okay? So, time's up, 5 minutes are over. Now you enter the room, then you have two examiners, and you will greet the examiner. The examiner will tell you that this is the patient or surrogate, and you have 14 minutes, and this is the history taking station. Then you go, and then you're faced in front of the patient or the surrogate there. Now, here we have two things to accomplish before we start the history taking. One is the introduction part. The second one is explaining what is the purpose of your meeting. So don't forget to do these two things. And the first thing you would say is, yes, I am Dr. Praveen. I am one of the, you can say, you're one of the candidates in the exam today. And just confirm the identity of the patient. You can say you're Miss Owens, you're 24 years old, right? Okay. So then the next part would be to explain the purpose of your meeting. And then you can say, like, look, your GP has written a letter to me that you have so and so problem, and I'm here trying to talk to you and get some more information. Is that okay? You can say, is that okay? And can you tell me what is happening? Okay? Tell me a little more about your problem. These are all open questions you're supposed to ask. So remember, the moment you enter, there are two parts. One is your introduction part, other one is explaining the purpose of your meeting. Okay? And then the patient or the surrogate will start talking. The patient and the surrogate has some information that they want to give you. My suggestion to you is calmly sit and listen to it. If at any point you felt what the patient told you is little confusing to you, or you haven't understood, make sure you ask questions to get little more clear information from them. Because that information, the first paragraph information which the surrogate or the patient gives you, is important. So if you listen to that carefully, you will get the right information and you will get the right direction in which you need to go. Normally what happens is candidates are so anxious, they're so prefixed and biased in their approach that they don't even listen to what the patient told you. Then they would start just firing away the questions. So you're all so anxious to ask questions, but pause a little bit. The patient is talking. Listen and see what they are saying. Then your job starts. Okay? But if you're not clear about something, ask and get clarity from the patient. Then comes your questioning. History of your presenting complaint. So you know what is a presenting complaint, and you'll take little more detailed history of that presenting complaint. And in that process, there are cardinal symptoms associated with each system. Like you have a respiratory system where the cardinal symptoms are cough, sputum expectoration, breathlessness, wheeze, hemoptysis, chest pain, and you have systemic symptoms like loss of weight, loss of appetite. These are fundamental basic questions you are expected to ask if it is a respiratory case, or if it is a cardiovascular case about chest pain, breathlessness, syncopal attacks, pedal edema, okay, and orthopnea, so it's such and such questions, okay. So history of presenting complaint, if it is a system related problem, you ask the cardinal symptoms of that particular system, and then you move forwards, okay. And once you've covered the main complaint related questions, you will go to the system review. I've already told you what to do with the system review. And once you finish the system review, it will be the past history. Now, in the past history, there are few standard questions you will be asking. The first and foremost question is if the patient had any similar problem in the past. Many times, candidates tend to forget this. If there is a case of a headache patient might be having headaches in the past, and unless you ask, they won't be telling you. So make sure in the past history, the first question you ask is, did you have similar problems in your past? And if the answer is yes, you ask about when did this happen, what happened at the time. Is that problem similar to the one which you're having now? Okay, and how things have been in between these two periods, before, when it happened in the past and happening now, how was this gap of time, and how did you do in that period? So it's important to ask the similar problem in the past. Then you will obviously ask about any past medical illnesses like diabetes, hypertension, heart attacks, strokes, seizures, thyroid problems, and all that. And then don't forget to ask about any operations the patient had. So, three standard questions: any past history of similar complaints, medical illnesses in the past, any operations in the past. If they say they had an operation in the past, you will ask about when it happened, what for it happened, and were there any complications after the operation. Okay, these are standard questions you will ask. If somebody says, yes, I had a particular surgery, then you will ask these questions. So you need to practice history taking. It's very, very important. When you have thoroughly practiced it, you know what question to ask. It'll be like a cakewalk for you in the exam. Okay? And then after the past history, you have the family history. In the family history, once again, the same thing. You can ask, is there anybody in your family who has similar problems? Once again, like, for example, a case of headache, there may be a patient's mother who might be having headaches. So, if there is any family history of similar complaints. Now, remember, this question in family history may be relevant to certain symptoms, may not be relevant to certain symptoms. So I wouldn't say this is a standard question in family history to always ask. I leave it to your discretion. If this particular complaint or a problem you think can run in families, you can ask this question. Otherwise, skip it. You don't have to. And you ask about any medical illnesses in family. Another important question you can ask in a family history is about, do you have any problems or diseases which run in your family? Okay, so that's again a good question to ask in family history. Then comes the medication history. Many times I see that in the rush of history taking, candidates do miss asking about medications history. If the patient is on medications, they tend to keep a list of the medicines with them. They will show you a card or a paper containing a list of medicines. Then the moment you see it, please go through it. It's not like you just see it and just throw it away. Don't do that. That just shows that you're not very professional. Everybody, the examiners are observing you. The patient will notice it if you just ignore it and throw it off. So have a glance, go through the list of the medicines if a card or a paper has been provided. Just check if they are tolerating these medicines well or if they're having any side effects from these medications, and also ask if they have any history of allergies. Okay, so all these important sub headings where you cover some questions, they just hardly take less than a minute time. So let me ask about this medication history here, just as an example. Okay, do you take any medications regularly? And the candidate gives you a card. I'll have a look at the card. Okay, so I note that these are the medications you are taking. Are you tolerating them well, or you have any side effects from them? The answer may be yes or no. And then you say, are you allergic to any medicines? Then that's it, done. Go to the next section. Go to the social history now. In social history, you can place your order differently. Like somebody can do social history immediately after this, or a personal history. It depends. So social history, are you married, are you single, do you have kids, are you planning to have kids? And then after the social part, you live with your family or you live alone, this kind of questions you can still ask. Then comes some personal questions. Now when it comes to personal history, there always has to be a warning, okay? Especially when it comes to sexual history, especially when it comes to obstetric and menstrual history. Not so much in a menstrual history or obstetric, but definitely in a situation of sexual history. You have to say like, okay, I'm going to ask you a few personal questions. It might be a little uncomfortable for you, but I need to know and get this information so I can assess the problem correctly. I hope you don't mind it. That's it. That's a good warning shot you are given, and then you proceed further. So I'll cover the sexual history first. There is a tendency to have little hesitation when you're asking sexual history, especially if it's a woman. My suggestion to you is practice it in such a way that you don't show any hesitation, and at the same time, you're not insensitive or not empathic when you're asking this question. Okay, so are you sexually active? Answer is yes. Okay, you have a single partner, or you had multiple partners in the past. Now, there are times where people stop at this point about if somebody says multiple partners, they assume that this person is automatically at risk for sexually transmitted diseases like HIV and things like that. That's wrong. That's not the way it is. People tend to have multiple sexual partners in some cultures, so it doesn't mean that they are at risk for HIV. The important question is that were they practicing safe sexual practices or protected or unprotected sexual practices. So somebody has multiple sexual partners and the unprotected sex was there, then that means the risk is more. Okay? So, and also about any instances of any homosexual activity. All right? So you can stop there. I think this much information would be quite sufficient. You don't have to dig in too much. Then the remaining part of the personal history will be about your smoking. Are you a smoker? Have you smoked any time in the past? How much you've smoked? How long have you been smoking? And if you have quit, when did you quit? Okay. And about alcohol, how much you consume, how frequently do you consume, what do you consume? And if somebody who's a heavy drinker, you will go through the CAGE questionnaire quickly and then complete that part. Okay. Then it comes to the recreational drugs history. Ask about, do you consume any recreational drugs? Have you had consumed in the past? Have you ever injected drugs? Okay. And then finally, in the personal history is your obstetric and menstrual history. Obstetric history, have you had kids before if it's a woman, obviously. If you have kids before, and how many you had, and were there normal deliveries, or was there any complication before or after or during delivery? Okay. And in menstrual history about menses being normal, sometimes you can be as brief as menses are normal and any trouble during your menstrual periods. Okay, and that just finishes the personal history. Then your occupational history. You can ask like, what do you do? What's your job? Are you working? And so when they say a particular job they do, how long they've been doing that job. And then particularly when it comes to respiratory and some other instances, you may go a little deeper into the occupational history, mainly to look at any exposure to carcinogenic agents or agents which can cause lung disease like interstitial lung diseases. Okay, and if the scenario which you got does suggest like there is a respiratory problem, you need to ask about if there is any exposure, and then any protection against that exposure is being followed by the patient or not. At this point, you may wish to ask if the current problem is impacting the work of the patient. Are they able to perform their job properly, or is there any impact of the symptoms or the problem on their job? Then the dietary history. I think I've already covered this, that dietary history is important in certain scenarios. The question to ask, are you a vegetarian or you're non-vegetarian? How much quantity you take? Has the quantity come down, or are you eating more now? If there's a case of a weight gain, then such questions will be relevant. And then finally, travel history. Have you been traveling lately? And if yes, any areas, and when you were traveling or when you were there, have you had any problems? Okay. So these are all the history you can take. And finally, when you finish through these sections of history taking, after that you have to remember that you need to ask this question. So you can say, look, I've been asking you a lot of questions now. It's possible that I might have forgotten something to ask you, something which may be important, and I might have forgotten to ask you. If there is something like that, please tell me now. Okay? So that way you can get some information from the patient or the surrogate. It's not possible that you will do a perfect scenario covering all the sections of history taking perfectly. Every question is asked by you. It's not possible. It doesn't happen. When you are teaching, when you are talking like this, you will talk everything because it's easy. But in the real exam situation, it's not possible to do it perfectly. So asking this last question does certainly help you in many ways. Okay, so you ask the questions and you finish the history taking. Now it's possible that you finished very early and there's a lot of gap. There is still, say, 4 minutes, 5 minutes time left. Now you don't know what to do. Sometimes in the exam we see that candidates are sitting quietly, the patient is sitting quietly, we are sitting quietly, the whole room is quiet. Suddenly the candidate remembers that there's a question they've forgotten to ask, the candidate will go and ask, and you can do it. I'm not saying it's wrong to do it, you can do it. But there's a way of doing it. You can't just say, do you smoke? Do you drink? No. Okay? So don't do like that. Try to act as professionally as possible. Okay? The way you conduct yourself goes a long way for us to decide whether you're a good candidate, you're on the borderline side or on unsatisfactory side. Sometimes for us the dilemma is whether to put you on the borderline or unsatisfactory. Sometimes the examiners might err more towards borderline because you have been quite professional and you are conducting yourself well, and in the exam pressure you made some mistakes. Okay, so I have a hope that examiners will consider the exam pressure is something which can undermine somebody's performance on that particular day. So yes, you remember something to ask. So you can say, like, you've been quiet, and suddenly you remember something to ask, and you say, okay, looks like there's something I remembered to ask you. I'm sorry, I forgot to ask this earlier. So do you have any problem, related to something, whatever you wanted to ask? You can start the conversation again like that. Don't start it abruptly, jump into the history directly, but ask politely and make it's like a conversation, obviously. All right. Okay, so still there is a big gap. Still you haven't got much to do. A lot of gap is there. So what you need to do in that gap, right? First thing, it's always a good practice to summarize. Summarize what you collected as information from the patient. So in history taking, it's always a conversation between you and the patient. Your purpose there is to sit, talk to them, extract a lot of information from them. So when you collected that information, it's important that you summarize it and then give a gist of the main points that you've collected that information from them, and then replay it back to the patient. And then you say, have you understood, is it correct, or is there anything wrong that I have told you now? So you just check that accuracy of that information you've collected and the summary which you have made. If there are any inaccuracies, the patient might point out to you. And subsequent to that, you need to give your possible diagnosis or differential diagnosis. So, you told me that you have such and such a problem, and you don't have this, you don't have that. These are your main things, and your family history is this, and then that's the brief summary which you made. And then you can also it's important that you ask about concerns. I think I've covered this earlier, but I'll repeat it again now. asking patient concerns is very important. If you have, there is a time where there is 2 minutes, there's a warning given by the examiners, there is at 12 minutes mark that there are 2 minutes left. And I had told you earlier that you have to at least cover the concerns of the patient during these 2 minutes. But if there is a big gap, obviously you have to do it. And then take detailed list of the concerns the patient has and try and address those concerns because you have a big gap to fill up. Okay, and then there's still more time. There's still more time. You summarize, you address the concerns, you've given the plan, what you're going to do, you're going to explain what investigations you're going to plan, what treatment you're going to start, or if you're going to refer to a particular specialist or a specialist nurse, or you're going to talk to your consultant, you're going to arrange a follow-up appointment. You've done all that part, okay? But still there is a gap. Still there is a gap. You had finished very early, still there is a gap. So my suggestion again to fill the gap, it's not necessary always to fill the gap, but you are trying to score much more than you already scored earlier. Then you can say, like for example, I'm just giving you an example, that if you have planned that patient needs an endoscopy or a colonoscopy, and then see in the plan I had told you that we might consider doing a camera test, which is a endoscopy. Do you have any idea as to what endoscopy is, or have you had endoscopy earlier? Then the patient might say something. Would you like to hear about how the procedure is done and what it involves? And then you can fill the gap by explaining briefly about what is endoscopy and what is colonoscopy. I'm just giving you an example. So these are all the ways where you can fill the gap if you have time left. Now I'm coming to another instance where there is not much time left. You had 2 minutes time at 12 mark, and then 2 minutes time, but you were still doing some history taking. You didn't have a chance to summarize. You didn't have a chance to ask the concerns. You didn't do much. You were just taking history. Don't feel too guilty about it. It does happen in the exam. Okay? But if you have taken a good history and if you've asked the questions correctly to the examiner, you can tell the examiner that, I'm sorry, I didn't have enough time to talk about the concerns of the patient, which I would have certainly done if I had little more time. I would have normally done this part where I asked questions about the concerns, and I would have explained the patient more about the differential diagnosis. Sorry, I couldn't cover it in time. Being honest is important. Showing your awareness that you are aware of all these other essential parts, but admitting that you didn't have enough time and you could have done it normally. So you're honest here, and then you are also showing your knowledge that you are aware of such things. That's a good thing to do. Okay. So, and then a situation where you had time. You had 2 minute time or maybe 3 minutes time, and then you know that you cannot miss asking the concerns. All right. So, and the summary and the plan. Okay. And as I told you earlier, when you're giving a plan, avoid medical jargon as much as possible. As much as possible. Keep it very simple. Use simple language. Don't complicate things too much. Examiners don't like such things where you use a lot of medical terms. Try to keep it simple. In the process of trying to, impress the patient, some candidates tend to use a lot of medical words, and then, they are making a mistake by doing that. So, in the end, the last part is, and the most crucial part for me, and this is how you should all be practicing history-taking skills. My suggestion to you is, please go to the Royal College website or Google MRCP PACES sample mark sheet, okay? And then you will get a PDF file which contains all the mark sheets of different stations in the MRCP PACES exam. Now that we are covering history-taking topic, pick up the history-taking marking sheet and quickly go through that. And then when you're practicing, please do it always. go through the mark sheet. I have the mark sheet in front of me here. Now there are 1, 2, 3, 4, mainly 4 skills which are tested, and the examiners have to mark you in these 4 skills. The first skill is skill C, clinical communication skills. It's funny, isn't it? You are doing a history taking station, and then the first skill, which is in the mark sheet mentioned, is clinical communication skills. Now it says that you will take a good history, and which is systematic, which is thorough, which is fluent and professional. I was telling you, try to be as professional as possible. Don't overdo things. The many times I see that they will talk a lot about, okay, I'm going to tell you, we're going to take this history, I'm going to ask you a few questions, I'm going to do this, I'm going to do that, please don't mind this, please don't mind that. There are a lot of things I don't know from where candidates pick up. Keep it very simple. There are no extra marks for doing all such things. It's very simple. You're here for a purpose, you explain the purpose. Yes, you will make a rough note of it, and then you do it or you mention it, you don't mention it. I don't think it makes any difference whether you say like, okay, I'm going to make a notes, it's going to be confidential, please don't mind if I'm writing in between. I don't know whether it will make a big difference or not. For me, as an examiner, it doesn't make any difference to me. So you might skip it. It's not necessary. It has no marks here. And it is fluent and professional manner, and it is systematic. Yeah, systematic. The reason is that you cannot be going on taking history and then you stop, come back, and then go back to another history, and then you'll come back again. Don't do a to and fro thing. Go in a systematic order. Okay. And then there is assesses the impact of symptoms on patients' occupation, lifestyle, and activities of daily living. I told you this has to be covered during the history about the impact these symptoms have on the patient's occupation and a daily life or their lifestyle. And also the communication part. The communication part is where you explain and start talking to the patient now after collected all the information. That has to be accurate, clear, structured, comprehensive, fluent, and professional manner. So that's how your communication skills are tested here. Then managing patient concerns, you will detect, you will acknowledge, you will attempt to address the patient's concerns, confirm patient's knowledge and understanding. It's always a good question to ask. So I have explained all these things to you. Have you understood anything, everything, or is there anything you haven't understood? I can explain again. Okay. So understanding, checking the understanding of the patient is a very important point, and there are marks for it. You are attentive, you are listening when the patient is talking, that is important, and then you are empathic. Okay. Differential diagnosis and clinical judgment, this is with what you do with your examiner. The examiner will ask you questions about the history that you've collected, what differential diagnosis you made, and why you think that is a differential diagnosis. So you have to go back to your history and pick up the points which support your diagnosis or your differential diagnosis. You can't just say as a guesswork. There has to be a corroborative evidence in the history to support what diagnosis or differential diagnosis you've made, and then the plan you've made. The examiners will ask you questions about how will you investigate further. Try to be very precise. Don't go about this, that. You're wasting time. We won't have patience. We have short time. We need to mark you on clinical judgment. So we will want a candidate who talks very fluently and precisely about the tests, and then why you want to do those tests, what are you going to do next. So the question and answer session with the examiners will be very specific. Try to be as professional as possible. We all know that you have the knowledge, you have the information, but how you present it to the examiner matters most. If you do well, you will be on the satisfactory side. Okay, so a lot of planning, a lot of practice. Okay, in history taking station. Okay, and don't argue with the examiner. Don't argue with the examiner. Just talk to them nicely, face them. Don't look here and there. There won't be any surrogate or patient sitting there. So talk to the examiners, and then you'll do well. So I hope this video, although it's a little long, has been quite helpful to you. And if you still have any questions, I will leave my contact details. You can get back to me with questions. And if some of you, if you are interested and if you show some interest, we can do some sessions separately, dedicated sessions. And I'm also planning to do some similar video on communication skills. So if you are interested, we can do separate sessions on a particular day as a course. Please do let me know and try to contact me if you have any queries or you are interested in any course. Okay, thank you and all the very best to you.